All righty. Good evening. My name is Tim Gibbs with Delaware Health Force and the Delaware Academy of Medicine, Delaware Public Health Association. I'm joined by Christy Hadley from the Sussex County Health Coalition. We're glad to have you here for the late fall 2024 mini medical school that we're doing this time in partnership with Lored and Beebe. And let me go ahead and move this to the next. So these are social media tags here and also the website URLs for Sussex County Health Coalition and for Delaware MiniMed. And I'm going to go ahead and drop those into the chat. Well, nope, I'll drop them into the chat in a while. I do want to point out to everyone that we're going to try doing attendance a little bit differently this time. In the webinar chat, you're going to see a link to SurveyMonkey. I need each one of you, please, to go ahead, click that link, and complete the very short survey. It's literally asking for your first name, your middle initial, your last name, and your email address. Once you've done that, we'll know for sure that you're here. Fitzgerald and Kennedy, please use the Q&A to ask a question. We don't do raised hands in this particular setup, sorry. And Q&A, by the way, is on your bar next to chat. Okay, moving on along here about the program. So the Academy of Medicine was founded in 1930. We've been doing mini-med since 2009 continually. The funding for this particular mini medical school series is provided through state and local fiscal recovery funds from the U.S. Department of Treasury and the state of Delaware, more frequently known as ARPA. And again, to folks who are raising your hand, please put your questions in the Q&A and Christy will respond to them. So as I mentioned, this is a partnership between Sussex County Health Coalition, Bay Health, Beebe, that should say, and Lored. We'll have to get that changed. You can attend as many of the mini-med sessions as you would like to. If you are going for the signed certificate that gets mailed to you, we need you to do two things. Number one, we need to have your home mail address to mail the certificate to. And I'll be going through the registrants and making sure that we've got home mail addresses. I've already contacted one or two of you. Number two, you need to either attend all 6 sessions live and have signed in using SurveyMonkey, or 5 sessions and you can do one and only one makeup session. The way that works is we're recording this evening's presentation. Ultimately, in a day or two, it'll be posted at delawareminimed.org. And Christy, if you could type that into the webinar chat, that would be great, delawareminimed.org. And then the video will post there along with the speaker's presentation. So that's the way that works. 6 sessions live or 5 sessions plus 1 makeup. You will email me after you've completed watching the video, and I'll ask you a couple of questions just for you to demonstrate your knowledge of what you learned watching the recording. There's no continuing education credits available for this. There are no grades or tests, with the exception of if you miss a session, then you are going to have a couple of questions to answer for me. Why do we do this program? There are multiple reasons. We enhance health literacy for our communities. We're exposing middle, junior, high school, and undergrad students with a range of topics and types of providers as part of career goal setting. So it's not all going to be physicians. Medicine is far broader than just physicians. Your presenters are going to be sharing their career pathways with you as a part of their presentation. In other words, telling you how did they get, well, where they got, what was the decision-making process, what were their challenges, how early did they start thinking about doing what they're doing now, and so on. And this is a safe space to encourage a dialogue between you all, the students, and the various types of providers that we have, where it's not your health that we're talking about. And along those lines, when we get to the Q&A, which is all at the end of the presentation, you can't ask any personal questions. That gets us into privacy area concerns. And if we see a question asked in the Q&A, then we'll flag it. And I will do my best to change the wording so that it depersonalizes it, but please be aware of that. I've mentioned a couple of times, don't raise your hand, use Q&A. This is a webinar, not a regular Zoom meeting. You don't see each other. You only see myself, Christy, and this evening's presenter, and therefore we're using the Q&A feature. There's something called the Delaware Youth Medical Academy. If you have completed 3 series, meaning you've gotten 3 hard copy certificates sent to you, you become eligible to be a member of the Delaware Youth Medical Academy. And basically it's based on the number of sessions, the number of points, and there are some perks to being members. Some bragging rights, you get some bling. We also will hook you up with some counseling and whatnot, and career promotion experts who can help you on your way towards your degree or your future education for that matter. This is only for 5th grade through graduate students. It is not available to adult learners. We're glad you all are here, but the Youth Medical Academy is strictly for youth. I think I've already covered that. Christy, do you want to tell us about the Sussex County Health Coalition, please?
Sure, really quickly. Sussex County Health Coalition is located physically in Georgetown. However, we help all individuals within the Sussex County region. We also help individuals within Kent County as well. We basically, what we do is we engage communities in collaborative family-focused efforts to make sure that we're improving the health of all people's youth, children, and families. So the way that we do that is by raising community awareness of health issues that may arise within communities. We make sure that we're raising the voice of those communities so they can let individuals know and organizations know about their concerns and ideas. And we engage with other community-based organizations throughout the 2 counties to ensure that we are promoting community health. And we develop and mobilize community resources. We provide a lot of workforce development programs. Right now, we're working through community health workers and providing some stipends and some scholarships and different things for individuals to go down that pathway. We build capacity for policy and program development, and then we evaluate and report out on all of the impact that we're doing.
All right. Thank you, Christy. So this is what the fall session series looks like. This evening, we're going to be talking about behavioral health. Next week, women's health. The following week, community health work. And Christy was just mentioning that. The next week, family medicine for specialized populations. The next week, working with the addictions and addictions population. And finally, the CEO and president, Dr. David Tam from BB Healthcare, is going to be talking not only about his own career trajectory, how he's gotten where he is today as a CEO, but also about his own experience with having a stroke. That will be a very interesting session, and he'll be talking about stroke as well. So now to the good part about the speaker. Christy, I'll let you do the honors.
Great, thank you. We'd like to welcome John Russum from La Red. He is an LCSW. He is the Behavioral Health Administrator there at La Red Health Center in Georgetown. His education, he has a bachelor's and master's of social work from Delaware State University. Over the 20 years of experience in behavioral health and substance use disorder treatment was in adolescents and adults. Since joining La Red Health Center in 2020, he has led the behavioral health unit. He's managing a team of licensed therapists, psychiatric nurse practitioners, and case managers. His team connects patients with critical behavioral health services and substance use disorder treatments. Previously, he served as the director at Dover Behavioral Health Systems, and he also provides psychiatric evaluations for patients admitted to Bay Health. We welcome John and take it away.
Thank you.
All righty, very good. And everyone noticed that now in the webinar chat, you have the website link for DelawareMiniMed.org. If I could humbly recommend, go ahead, open that up, make a bookmark now, put it on your desktop, do whatever you do, so you can refer back to that. I will go ahead and stop sharing my screen. And John, it's over to you.
All right.
Perfect. We can see it.
Okay, you can see it. Great, great. All right. Good evening, everyone. My name is John Russum. I am the Behavioral Health Administrator at LRED. So my journey did not start in behavioral health. So my journey started in 1994 when I started the psych program at Delaware State University. I had been in business before then. I did not like business. I didn't like sitting in a room with a book, writing down accounting information. So I applied at Delaware State University, was accepted, and started classes doing Psych 101. During that time, I was able to secure a job in radiology at Kent General Hospital. I was a radiology assistant. What I did do is I assisted with radiology technicians and radiologists. I developed x-rays. I assist in special procedures. Special procedures were non-invasive, like angioplasties, where it was done in special procedures room, which was fantastic that I got that experience with it. Also, help patients out and assist with putting away supplies. Later, I was transitioned in 1997 to a support tech role. I was still in college for my undergrad in psych. As a support tech, I stayed as a radiology assistant, but I also added a phlebotomist. Phlebotomy is the person that draws your blood when you go to the lab. So I was able to get my American Clinical Society Pathology board certification with phlebotomy. I also trained in EKGs, doing Holter monitors, doing stress tests, and also performing EKGs on the floor. Little side note there, because this wasn't part of what the support techs did, I also became a part-time or a on-call autopsy assistant. And I did that because at that time, I was actually looking to go to University of Alabama as a surgical PA. And I needed to know if I was able to work on people. So I became an autopsy assistant, which was a lot of knowledge-free education, if you will. I mean, all this now, people go to school, become a phlebotomist or an EKG tech. I was able to get all this back in the 90s free, which was a great experience. So afterwards, I did graduate with my bachelor's in psychology, and I requested to transfer to the psychiatric unit. At that time, it was called the St. Jones Center, and it is not located in Kent General. It was moved out, the unit was moved out to Horse Pond Road. So it was a standalone psychiatric hospital. When I started there, I was a psychiatric technician, and which involved a lot of contact with the patients, which was great. Patient safety, milieu management, making sure that the patients were where they needed to be, if they were supposed to be in groups, if they were supposed to be doing activities or at meals. Also for the patients that were on 15-minute checks, 15-minute checks are what you do when patients are on suicide watch, where it means every 15 minutes you have to lay eyes on the patient and then you have to document, what the patient was doing, where you saw them, and that they were safe. Also learned how to do education groups on things such as depression, coping skills, triggers, warning signs, and a big help was attending treatment team. So in the mornings, we had treatment team, which was made up of the psychiatrist, psychologists, social workers, nurses, and psychiatric technicians. And we went around and we talked about each patient individually. And we were able to get insight from the psychiatrist, which really was very helpful to try to understand the patient better. So then when you did meet with the patient, you could give them individual treatment from what you've learned in treatment team. While I was a psych tech, I did start my master's at Delaware State in social work. While I was attending Delaware State for my master's, I had two field placements. The first field placement was in South Lake Forest, where it was an education field placement. So there I counseled students. I attended IEP meetings, which is individualized education program, where we talked about what the patient needed to succeed as a student and pass for the year. We met with the parents, met with the student. I also did some community outreach and home visits while I was at that intern. It gave me a wider knowledge of the education department and its strengths and weaknesses, which helped me later in my career. My second internship was at James T. Vaughn Correction Center, which is Department of Corrections. It was my last field placement, and there I counseled inmates. I did education groups. I shadowed the corrections counselors. I got to learn the ins and out of the Department of Corrections. While I was there, I had a great experience. The Correction Center was developing a new unit called the SNU, which is SNU, and it was the Special Needs Unit, which is the unit they developed for patients that had psychiatric issues. So I was able to see how that looked like from the start up, which was again another really great experience that I had. And then I graduated my master's in May of 2003 and started immediately, like I think I started before I actually walked as a social worker at the St. Jones Center. And so this was my first real social worker job. And basically when we got a patient, I met with the patient within 24 hours of their admission. I did a psychosocial. A psychosocial is a document that we use that you discuss things such as what the presenting problem is, things that we need to know about the patient, any past history, any substance use issues, family history, what the patient wants to work on, how did they learn the best. It's a very long document that we fill out for every patient every time they come in. And it's required by the Joint Commission and Medicaid. Then I also did individual therapy, which I would meet with the patients one-on-one to discuss any crises that they were going through and try to help them the best that I could. We also did group therapy, which we mostly focused on what people's strengths were, what their triggers were, and how to develop coping skills for those. I also did family sessions, which had to be done before a patient could leave the hospital. With family sessions, what we worked on was trying to sometimes reunify the family or strengthen it. Sometimes there's a lot of stress when you have one of your loved ones having a mental health issue. So we tried to problem solve and tried to help the family be able to help the patient more when they were discharged. And then the last piece of it that I did was discharge planning, Discharge planning is very important, and it's usually started when the patient is admitted. And it's part of the reason why we do the psychosocial, to get as much information as possible. So when you do the psychosocial, like I said, you also find out, who the patient currently is seeing as far as a psychiatric prescriber and provider, and what had been the barriers before then, if they're having problems with transportation, if family not supportive. So you try to collect all that information. So when you do the discharge planning piece before their discharge, that you are ahead of the game, and that you can give the patient the best discharge that they can have. The better the discharge, the more successful the patient will be when they leave our facility. And then in 2006, after I had been a social worker for about 3 years, I passed my LCSW exam. So I became a licensed clinical social worker. All right. And in 26, I had a great opportunity. I was still part of Bay Health, and they were developing a psychiatric consult team, and I was able to get on the team. As a psychiatric consultant for Bay Health, I performed consults for depression, anxiety, bipolar, mania, schizophrenia, psychosis, substance use, somatoform disorder, capacity, etc. And with the consults, you would basically write down the reason for the consult, the history of the present illness, what's happening, what is the patient experiencing, how long have they been experiencing that, their behavioral health history, their substance use history, medical history, medications, family history, socioeconomic history, labs, mental status exams. Then you write what your impression is, which is usually the diagnosis, and then recommendations. Now, when I do that, I review it with my psychiatrist, which is either Dr. Mirza or Dr. DeSimone. And then they sign off on it, which is, fantastic, because I'm the one that goes in, I see the patients, and then I review it with the psychiatrist. In 2007, and became the director of director of social work at Dover Behavioral Health Systems. Sometimes when you do your job pretty well, even though you don't have leadership skills, you tend to find yourself put in a leadership position. So when I became the director of social work, I had less patient contact. I did help out, especially during high acuity times, but I was busy doing performance indicators, doing audits of charts, making sure that we were compliant with Joint Commission, Medicaid, Medicare. We had surveys with the Joint Commission, Medicaid, Medicare. They would come in, they would take a look at our charts. They would ask our staff questions. They would go around and talk to the patients to make sure that everyone was doing their job and that the patients were getting the best care that the patients could possibly get. Again, I was in a treatment team setting, but this time as a director, you are the head of the treatment team. So your job in this setting would be to make sure that the treatment team goes smoothly, that everyone comes prepared. When you bring up a patient's name, everyone can give the feedback they need to give, so that the treatment team can move on as it's supposed to be. Now, at lunchtime, I would also have to go to a flash meeting with the other directors. And in that meeting, I would have to sit there and we would talk about what patients got admitted, what patients got discharged, what if there were any problems with the patients, if there was anything that we need to do differently. So we would talk about that. And then that information, either we did action to that right there at that moment, or that was information that I would take back to my treatment team the next day. It also included me doing staff performance reviews. That would come from the audits I did, and I would have to sit down the social workers, activity therapist, and I would have to discuss, how well they were doing, what their strengths were, what their weaknesses were, what things we wanted to expand on. So that was part of the staff performance reviews. In this role, I also had to develop a lot of policies. Policies are not my favorite thing to do, but it was part of the job. So, and as the director of social work, the departments that I oversaw were social workers, activity therapists, the partial hospital program, and the intensive outpatient program, and also transportation. When I became the director of social work, we didn't have a transportation department, but it was evident that there was a big need for a transportation department so that the patients that we had could get home after they were discharged, and also that we could get patients to our partial and IOP programs. Because without, patients being able to come, and transportation has been very difficult in the state of Delaware over many, many years. So this was a way to help that out, help the patients be able to get treatment and take that barrier away from them. A couple of years later, I became the clinical services director at Dover Behavioral Health. And when I became that, I helped open the Georgetown site. We do have a Georgetown partial IOP program that's on Bedford Street. And I also, one of the big takeaways from that time was I was the holds reduction champion. So inpatient psych is a lot different than outpatient psych. And there are times where patients need to be restrained. And we looked at that as if we had to put hands on a patient, that was a failure of treatment. So my job as the holds reduction champion was to find better ways for our staff to de-escalate patients without having to put hands on them. In the first year that I became the holds reduction champion, I reduced holds by 15%, which was pretty nice. Which brings us to 2020 is when I started with Lorette Health Care Center as the behavioral health administrator. So Lorette Health Care Center is a federal qualified healthcare center. They're called medical homes. At Lorette, there are many different departments. There is medical, which is made up of primary care, pediatrics. We have women's services, we have dental, and we also have behavioral health / substance use. So I am the administrator for the behavioral health / substance use department. So as an administrator, I was able to still see some patients. I do carry a caseload. I usually see about 12 patients a week. But on top of that, I started to learn about grant writing. And then once we got grants, I had to learn how to manage the grants. When you write grants, you've got to put down the things you need. You've got to make a budget. You've got to follow the budget. And you also have to keep the receipts. So if you're audited, everyone can see that you've done exactly what you're supposed to do with the budget money. I also perform staff performance reviews, which requires me to again, sit with staff members when they're seeing clients, and then going over their strengths and weaknesses. I also have a lot of customer service. Sometimes we do have patients that are not happy, and they give me a call, and I have to talk with them and see what the problem is. Apologize for that they had a problem at Lorette, and see what I can do to help them get the services they need without a problem. Also training. I do a lot of training at Lorette. I do training with my department. We, every month we'll pick a topic like depression, ADHD, mania, something like that. And then we'll go through it, do an education and bullet points, and then we review it. I also am a CPI, crisis prevention person at Lorette, trainer. And every so often I have to do groups to teach our staff at Lorette how to do verbal de-escalation, because patients do come in and we never know what's going on, what precipitating factors are, and we try our best to calm our patients, calm them down, and try to talk to them. I also am in charge of community outreach. So I do have case managers, the homeless case managers. Some of the interventions that I have done since I became the administrator is we do haircuts for people experiencing homelessness. We do it 3 times a year, which has a big following. We also do health and resource fair in front of Lorette. It's usually the first week of May and the second to the last week of October. We just had our last one. It was on WBOC, which very excited about. Our one that we did last week was for Lorette Goes Purple, which was mostly focused on substance use disorder, Narcan, and getting everyone we can to Lorette. We also had other agencies there. We had BB there. We had Bridge Clinic. We had Contact Life, the Department of Veteran Affairs. So we had 30 different agencies there so that the community could come out and get, find out what services were available to them and their families. We also do Feeding Thousands with Mount Air Farms, which is basically on Thanksgiving and Easter. My case workers go to Mount Air, help them box up chicken, stuffing, and other items so that they're able to have a holiday meal with their families for free. And we distribute them out to the community. We also have a homeless outreach day, which is part of FQHC week. And for the last 2 years, what we've done is we've purchased book bags. That inside the book bag, there's a rain jacket, there's a blanket, there's socks, there's toothbrush, there's toothpaste, razors, different health things that they would need, deodorant, and we distribute them with water and also with a couple snacks in the bag as well. And we also have started a community refrigerators, which is at both. We have 3 locations. We have a Milford, we have a Seaford location, and I am located at the Georgetown location. And we have refrigerators at all 3. And in the refrigerators, there's fresh fruits, vegetables, which is open for patients to come and get if they need it. And as the behavioral health administrator, I supervise the psychiatric nurse practitioners, the licensed clinical social workers, licensed professional mental health counselors, the certified drug and alcohol counselors, nurses, medical assistants, and my homeless outreach case managers. So that's just that's what I do at Lorette. And that was my journey to becoming a licensed clinical social worker. And in the beginning, I wasn't going in that direction, but you never know where life takes you. I was looking to become a surgical PA. My journey has taken me this way, and I'm very happy with it. You can tell by the things I've talked about, I've gotten a lot of free education. I was always in the right place at the right time. When I was a social worker, a brand new social worker, we got this medical director, the psychiatrist, and he kind of took me under his wing, and he treated me more like a med student than an actual social worker. So I was able to learn a lot. And one of the most valuable things he's taught me, which I'll leave with you guys, is that insight is knowing that if you eat an onion, your breath will stink, and judgment is if you eat the onion or not. I use that all the time. And that concludes my presentation.
Thanks, John. John, if you have a minute, can you just kind of maybe give one of the cases within HIPAA rules and regulations, kind of a couple cases that you've been through and what that looks like?
So one case that I just finally finished up with was a adolescent. I think he's about 14. And he stopped going to school after when COVID started. And when COVID ended, he did not go back to school. So basically, he missed 3 years of education. So the first year, I wasn't involved with him. Then the second year that he missed, I was involved with him, and I got him into Homebound. So he was able to go to Homebound, and Homebound is where you go. In his case, he went to the library, and there were several students there, and the teacher would go there and work with the students at the library. He still had school avoidance, had anxiety about going to school. During during being out of school, he picked up a lot of weight, which was one of the reasons he did not want to go back. So we, talked about exercising. When he came in to see me, him and I would do therapy as we walked around the building. And his 8th grade year, yeah, that's the last year of middle school. He finished up with Homebound, and then he started high school this year. He went he didn't go the first day, but he went the second day, and he's been going ever since. So we were able to build up his self-confidence. I noticed that when he came to see me, he was wearing the same pajama pants, I guess they're called. And so I went out and got him about 4 different pair of the pajama pants. Again, he was struggling with his weight. We helped him out as much as we could. So, that was definitely a win. It took 3 years, but seeing the fact that he has gone back to school has been wonderful. Definitely very wonderful.
All righty, and here I'm about to hop into the Q&A and see. Okay, Nathaniel, that's a good question. You mentioned a lot of current jobs. Is that normal expectation of an average workload?
Okay, so oh, I that was through my career. The phlebotomy, the radiology assistant, the EKG tech, that was during my undergrad time. And again, that was when I was more focused on becoming a surgical PA. I was helping out with special procedures. So I was assisting the radiologist with doing angioplasties or angiograms. Angiograms is where they stick a needle in the groin area and they inject dye and they take pictures of the inside. So I was helping set up for that sterile procedure and setting up the IVs and things of that nature. As I graduated with my degree in psych, I became a social worker, and then after that, I became the director of social work, and this was all at the same place. So it was just because of my success as a social worker, I got promoted to be the director of social work, and then when that went well, I then became the director of clinical services and opened up a IOP partial in Georgetown and became the champion of the hold. Now, as a director of social work to the behavioral health administrator at Lored, I also 15 days a week, 15 days a month, I am a behavioral health consultant or a psychiatric consultant for Bay Health. So that's I call it my side hustle. I've been doing it for 20 years. And again, so with that, I am on call from the October 1st to October 15th, or actually October 16th at 7 a.m. And what happens is during that time, I check a voicemail and I get a call from one of the units at Bay Health, which is either Kent or Sussex, and they leave me a message saying that they have a patient in room such and such, and they need me to see the patient for said reason. And then I have 24 hours to go see the patient, discuss the case with the psychiatrist I'm working with, either Dr. Mirza or Dr. DeSimone, type it up, and put it in the electronic medical records. So I'm able to see the patient, come home, and type the notes from home, which is so much better than it was 20 some years ago when I started. But it's not normal, but it's something that I've become accustomed to. I mean, I was part of the initiation of the psychiatric consult services at Bay Health, and again, that's another area where I've got a lot of free education. When you consult and then you have to discuss the case with a psychiatrist, and then you have to discuss the rationale, you get a lot of free experience and free education. And I'm going to say this, if you have a chance to do something, volunteer for something, because when I first started doing the consult service, it was all volunteer. I didn't get paid for any of it for a year. But the information that I got from it, talking with the psychiatrist, finding out what they would do, what medications they would use, why would they use those medications, why wouldn't they use those medications? It's helped me out immensely, seeing patients as an outpatient provider. I found out things such as Wellbutrin. Wellbutrin's an antidepressant. Wellbutrin's an activating antidepressant. But if you take Wellbutrin and your patient drinks, it will lower the threshold of seizures, and your patient could have seizures. These are things that you pick up that they don't teach you in social work school. So having someone that will take you under their wing and teach you far more than you learned in college is, I can't tell you how amazing it is.
All righty. I've been answering some of the easier questions on the side here. Is medication the only way to fix or maintain mental issues?
No, it's not the only way. Sometimes you do need medication. A lot of times, people do well with just talk therapy. Talk therapy is just, finding out what the issue is, which sometimes is hard. Sometimes people think the issue is one thing when really something else is bothering them. Doing talk therapy, I would probably say, is the first step. If it's something as far as having suicidal thoughts or having mania or psychosis, those are definitely things that usually take medication. There are some circumstances that it doesn't, and I'll give you one. So, drug use. There's a lot of drugs out there. Recently, there is a smoke shop in Dover that is selling a synthetic marijuana gummy. And I've had a couple patients that have used those gummies and they have become psychotic, which under the DSM-5 would be substance-induced psychosis. And with a patient like that, sometimes they do need a medication at the crisis, but sometimes it's just the fact that the drug has to wear out of their system. And then they, majority of the time, go back to normal or as close to normal as possible.
Yeah. Interesting question, and a loaded one. I'll warn in advance. Does therapy always work?
Therapy works when people want it to work. There's
Good answer.
there's a funny joke, and sometimes I tell it to my patients, and it's, how many psychiatrists does it take to change the light bulb? One, but the light bulb must want to change.
Right. That's good. What's been the most challenging experience or position you've experienced thus far? You've encountered thus far?
All the positions have their challenges. Um, you know, um, being the clinical service director of Dover Behavioral Health was a big challenge. It was my first big challenge. And pretty much I was on call 24/7, 30, 31 days a month. If something went wrong, I had to go in. So that did take a lot of time and effort. It took a lot away from my family. Um, which happens when you get into a higher positions, corporate positions. You've got to and to be honest, I lasted in that position longer than most people last as a clinical services director. It has a high burnout rate. I was very happy to move to Lored, where it's outpatient. And I'm not on call, but I do get calls, from time to time at home, which is absolutely fine. So probably, and again, this is the other piece. When I was the clinical service director of Dover Behavioral Health, hospitals are responsible for patients 30 days after discharge. So if something happened within the 30 days that we didn't try to think or prevent from happening before they left, that falls on us. So sometimes you have sleepless nights.
So very pointed question here. Have you done anything related with or related to anesthesia throughout your healthcare journey?
No, I have not done anything with anesthesia, at all. I've never done any type of surgery. I mean, doing autopsies, you don't really need anesthesia. Uh, I've not.
Truer words never spoken. What does a typical day look like for you? What time do you get into work? What time do you get home? And does that actually mean that you stop work, or do you still have patient files that you need to look at and review and report on?
Well, now, I mean, it's much different than when I was the clinical service director. Now I get in work at 8 o'clock in the morning. Usually kind of take a quick walk around the unit, see what's going on, put out any fires before I get in my office. Then I, go to my office, put my bag down, I log into the computer. And I do probably I have three apps I go to. I have our EMR. We have electronic EMR, all scripts. And I'll log into that because it takes a while for that to load up. Then I'll load into my email, and also I will log into Paylocity and start just going through. So Paylocity is how we keep track of our staff's hours. So I'll just go approving all the hours from the day before. So that way on Friday before I leave, I'm not approving everybody for a week. I do it slowly. Check the email, see if there's any emails that need to be answered right away. And then I log on and I see if I have any patient messages on the all scripts, or any questions come up or patient issues. Sometimes that means getting transportation to pick up a patient for a appointment. Then after I get all that settled, then I start. If I have records I have to look at to sign off so they can be faxed to other agencies, I look through those records. Sometimes staff come to me with issues when I'm, in my office, which is fine. I have an open door policy. Doors open, come in, let me know what's happening. I try to help them out the best I can. I may have to call a staff or do a televisit with a staff member because, again, I'm in Georgetown. We have a Milford office and we also have a Seaford office. Sometimes during the day, I'll leave my office in Georgetown and go to Milford and Seaford just to walk around, just to make sure my staff know that I'm there for them and that, if they have any questions, they can ask me. My staff all can reach out to me on my text messages, and they text me a lot. They text me more than my family texts me. Then it depends on if I'm working on a grant. I could be doing training for crisis prevention where I'm teaching our staff how to do verbal de-escalation or it also teaches them if a patient puts hands on you, how to get away without hurting the patient. I could be in a meeting with the CEO, the COO, and the deputy director. So there's endless possibilities. Today, from 8:30 to 11, I was at Sussex Sussex Corrections Institute, doing a presentation about our reentry program that we're doing with the inmates at Sussex Correction Institute. So I was there talking with them about that. I've put on events. If it's, haircuts for the people suffering from homelessness, or if it's our health and resource day, I'll be setting up for that. Then in the afternoons on Tuesday, Wednesday, and Thursday, I see my patients. So I usually have 4 patients a day in the afternoon, which they come in like clockwork. Rarely have a call out, or a no show, as we call it. And you're right. Sometimes I do come home and I have to log in from home and finish a note or two up. Notes, we try to get them done within 24 hours. And then try to get some dinner, enjoy some time with my family.
All righty. I'm going to clump a couple of these questions together.
Okay.
First off, do patients have pre-established appointments with you, or are they walk-ins? And then related to that, how long is a typical session with a patient, if there is such a thing?
And I can talk with me, usually a typical appointment with a patient is 45 minutes to an hour. I tend to go with 45 minutes. After a half hour, people's attention span goes, even with adults. So I typically do a 45-minute session, and then it gives me 15 minutes to make some documentations or whatever I need to do before the next patient. So, and if you do too long with a patient and they start getting bored, they start losing interest, then they start losing interest in therapy, and then it can have a negative effect. Now, the first part of that question you had said was what?
Oh, do people who have appointments with you, were the appointments set up in advance, or can people also walk in and see you?
So this is how it goes. I mean, so the people that have appointments with me are patients that I'm seeing constantly. They're the patients I see every day. So how it works at Lured is that you call our behavioral health department, and my behavioral health nurse, Nikki, she picks up the phone, and then she'll make an initial intake for the patient. Nikki will collect all the history, medication, family history, all that good stuff. From the patient, or with her appointment with them, and then she'll set me up with she'll set one of the therapists, nurse practitioners up with an appointment with the patient. So Nikki will set the initial appointment up, and then once you see me, for example, I will go ahead and schedule the appointments before you leave the session. So after we get done discussing it, I will then go into the computer. I will set the next appointment up for you. I'll make sure, I'll ask you, what times and days are good for you. I'll set it up, and then I'll put it on a card, for a lot of reasons. It is so much easier if I do it, than to go back out in the waiting area and then wait for someone else to do it. So, and usually like the clients I have now, I've seen for a while.
All righty. I'm gonna paraphrase this question a little bit. So, at what age does childhood development become a potential mental health issue, a behavioral health issue that needs to be addressed?
Whew.
I should have prefaced that with, it's a loaded one.
Well, this is one of those things where the experience I had at school during my internship helped me out. So when I was the director of clinical services at Dover Behavioral Health, we would have patients that were in like 3 different state departments. DSSS, which is disabilities. They might also be with the probation, childhood probation, and also child mental health. And a lot of times they would fight to discuss who was going to pay for what services for that child. So, one of the big things is, you've got to decide what area that patient is struggling in the most. Someone with some cognitive impairment, they require a lot of behavioral treatment. And now schools nowadays have come up with better ways of having behavioral health paraprofessionals at school grounds. Sometimes depending on impulsivity, aggression, medications are used to help with that. So when you talk about someone with some cognitive impairment, you've got to decide whether this is severe, moderate, or mild. You know what I mean? And from that point, then you have to make decisions. When they become severe, then that patient gets admitted into a psychiatric hospital. And then if they've been admitted to the psychiatric hospital so many times, then the next point is, okay, now we're looking for an inpatient program that's geared towards patients with some cognitive difficulties.
All righty. So sort of following on that, do you work with individuals who are on the autistic spectrum?
So right now with Lared, I do work with some children that are Asperger's on the spectrum, but we're looking that they're mild. What I mean? We don't do a whole lot. Actually, this was brought up to my attention from Dr. Alakan, who's our chief medical officer, and he'll be presenting down the road here. He had a client that family had a child who had more moderate to severe, and we would then refer them out. There's a clinic in Dover now. I can't remember the name of the clinic off my hand, but we would refer them out to someone that would do that. Especially someone who's more moderate to severe, they're going to need probably interventions in the home. They're going to need a behavior specialist to go in the house, things of that nature. Where it's more mild, then, we could take care of it in the outpatient setting.
All righty. So you're with the federally qualified health center now, and even when you were in other clinical settings like I can't recall, was it BB or Bay Health?
Yeah.
Regardless, Bay Health. Insurance is often a barrier for patients. Are there resources to help the types of patients that you meet and see on a daily basis?
Well, at Dover Behavioral Health, it was a for-profit, which drastically changed things. When I went over to Lared, we're a non-for-profit. We treat anybody and everybody, no matter what your legal status is. If you have insurance or don't, depending on what you make, they do a sliding scale fee. And if you can't pay, you can't pay. So at Lared, I must say that we treat anybody and everybody regardless of everything, which is wonderful. That's definitely one of the reasons why I stayed with Lared, because they truly care about the community and the patients in our community. So it's at Lared, we can, take anybody on regardless of insurance, or legal status.
All righty. I'm going to link another couple of questions together. Um, this question is generally about you and about managing your own mood and state of mind. We all realize that sometimes things can get tense. How have you? How do you learn how to manage your own reactions and behavior when dealing in a situation that might be escalated?
And this is what one of the things I teach with crisis intervention. Um, so you have to be aware of what sets you off. You've got to be aware of these things. When a patient when a patient starts to raise their voice, it's very natural for us as people to start to raise our voice in return. But you've got to know that you've got to keep it low. You've got to keep calm. You've got to try to keep the patient calm, because if you don't do that, you're going to get the worst case scenario. um, by doing things as making sure that you're trying to keep the patient calm, you're trying to give answers, that you're trying to be transparent. That's another very important thing, is let the patient know that you're telling them the truth and that you're trying to do the best that you can for them. They may not like that, but they respect the fact that you're telling them that maybe you can't do what they want you to do. Um, you've got to be honest and transparent with the patient. You've got to try to keep them calm. And the huge thing is, you can't take it personal. When you take things personal, that's when it goes really bad. It goes south fast.
Right. Interesting you mentioned that. So I guess what, next Tuesday, the country has a big election, and let's just say that the stakes are fairly high. And with social media and broadcast television as pretty major influencers and inflammatory centers, how do you recommend to just regular people uh, to sort of moderate our mood and behavior, and especially our response on Tuesday and Wednesday of next week?
I mean, it's huge. There's a big buzz going around about the election already. I can't believe I was going through Facebook and I saw that you can actually bet on the election.
It is kind of like the new American Gladiators.
You can actually bet on the election. I was totally thrown back by that.
Yeah,
Uh, but I mean, no one knows what's going to happen. People become anxious with not knowing what's going to happen in the future. Depression is worrying about what happened in the past. Anxiety is fearing what's going to happen in the future. We've had many talks about things that could happen, especially with our community, our population. And I don't really watch the news for a certain reason, uh, but I actually caught some news and listened to them talking about deporting millions of people, um, which would definitely affect our population.
yeah,
Um, you know, um, from what I've heard people talk about, some people are talking about not sending their kid to school. Some people are talking about they're not going to come to work that day, just because of fear of the unknown.
right, right. So Nathaniel asked a great question. Diversity and inclusion seems to be important to work with in all patients. I would like to know more about the preparations to handle various situations. So, pointedly, you as a white Caucasian man, how do you how have you changed yourself to deal with populations, whether they're a different color, a different language, a different gender, a new gender? Tell us about that.
So, and again, this was something I learned very early in my social work career. My intern at James T. Vaughn. James T. Vaughn is the Supermax prison in Smyrna. I was the first student from Delaware State to go there. I kind of wanted to go there and I did everything I could to get in there. I got in there. And basically, during that internship, I was able to walk through the prison all by myself without any guides. And I learned very quickly. I never had a problem there because I gave everybody respect. And if you start with respect, it just gets better from there. I learned that respect is huge. I treat people in the LGBTQ plus society. I have great relationships with those patients. I have great relationships with my patients that are from other countries. I have interpreters. That's another great thing about Lared is that we have several Hispanic interpreters, and we don't have to use a language line. And I don't know if anyone out there has ever used a language line, but it makes therapy go very choppy at best. So with the fact that we have probably anywhere between, I don't know, 4 to 6 interpreters in the building at one time, makes therapy go very well. It helps you when you have an interpreter to get the therapeutic alliance, and that's another key word with social work. You'll hear a lot of key words with social work. If you go into social work in school, you'll hear start where the patient's at, which is huge. You have to start where the patient's at. The next thing is that you've got to build the therapeutic alliance. Many years ago, I was in a seminar class, and it was about therapeutic alliance. And the instructor talked about the different CBT, DBT, motivational interviewing, and said that the study was done and that those things all showed the same amount of success in therapy. The thing that made the therapy successful or not was the therapeutic alliance between the patient and the therapist. And you've got to keep in mind, you've got to listen to the patient. It's their treatment.
Right.
Sometimes I'll just listen.
And speaking of alliances in teams, another person wanted if the therapy does therapy work if a patient wants to change but finds themselves unable to? And I started to answer the question, and then I said, no, I'm going to stop and let you answer it.
Say that one more time for me.
Yeah, go for it. Yeah, so go for it. How would you
No, can you say that for me one more time?
Does therapy work if the patient wants to change but finds themselves unable to?
Well, that means that the therapy is going to go in a different course now, because now you're going to be working with the patient on how to make the changes. I mean, therapy, and to be honest with you, today in therapy, I told a patient that therapy is going to work out one way or the other. You may get the result that you want, or you may not get the result that you want, but it's still going to work. You know what I mean? And I'll give you an example. So a married couple comes in. Of course, what the end result is that the married couple stay together. But it might be through therapy that they realize that they're really not good together. And then therapy becomes, how do we break up successfully and then have good lives? You know what I mean? It doesn't, therapy isn't always to have that fairy tale ending. Um, but you'll learn from it, you'll grow from it. And the important part of therapy is, it's not like the therapist telling the patient to do something, it's the therapist helping the patient to understand what they need to do. So the patient really drives the therapy. The therapist is just more like a guide.
All righty. And one of the things that that I might respectfully add to that is that sometimes in the context of working with a team of different types of providers, it might be time to call in psychologists, psychiatrists. There might be, a lot of other things that play there, and that's why we work in teams. How do you know when the talk therapy has worked and is not needed any longer?
Well, it also depends on the patient. So I have a patient. She is an older female, and she lost her daughter to cancer. And when I first started seeing her, I saw her almost every week. Then we got through the holidays. Then we were able to move it every other week. Another year passed, and then we moved it to once a month. So, it depends on how the patient is doing. I mean, she's doing well, but every now and then she has an episode. When the patient feels that they've got as much out of it as they can, they've completed all their goals and objectives, I always tell them that they can always come back. What I do is I try to space out time. I'll try to do the once every month for a couple months just to make sure, as a kind of a parachute in case something happens. So I mean, you never know for sure, but you get that from the patient. The patient feels that they've successfully completed everything. You just let them know that they can come back if they need to.
All righty. Last question in the queue. This has been great. I think this is probably being asked by a parent or an adult. And I'm going to, again, paraphrase it. At what point should a parent, what signs might a parent be aware of that it's gone beyond what they can do for their kid and they want to engage some sort of professional assistance?
I mean, that is a huge area. It could be the fact that the parent doesn't feel comfortable with it anymore. It could be the fact that the child says, "Hey, I want to talk to somebody." There's a lot of things. Sometimes, I've had parents come in and it's I look at it and I think, oh, it's not that big, but they decided they wanted a therapist to come into it. So I mean, it varies. It varies, if it's mild, moderate, or severe. When we talk about that, and again, we don't know exactly what exactly is going on. So, if it's something where the kid wants to hurt themselves or hurt others, or hearing and seeing things that aren't there, definitely you want to get that checked out as ASAP. You want to either go to a ER, or you want to go to one of the psychiatric hospitals, especially if the patient wants to hurt themselves or others. So in those cases, you need to handle that immediately. Other cases, where there's a strain with the patient or the parent child, it depends on how severe that is. Are they not listening to you? Are they skipping school? Or, things of that nature. You may want to go ahead and go right into a therapist from that point, especially if you don't feel like you can handle that. Or, for example, if the child is pushing the parent's buttons, you definitely want to, go see a therapist, because, the last thing you want to do is, the child push your buttons and then you do something that's out of character and get into trouble.
All righty. Well, thank you very much for spending some time with us this evening. Christy, who do we have up next week again? I think it's Women's Health.
It is. It's Women's Health next week.
All righty. John, everybody, thank you very much. And for all of you who, 111 people are still with us. That's fantastic. See y'all next week. Take care. Bye-bye.
Thanks.